So, hello everyone. I would like to welcome you to Grand Rounds today, which is part of our Psychiatry DEI Committee's series on Just Talks. And we're very excited to have with us today Dr. Sidney Hankerson. Paul Rosenfield will be doing an introduction. I just wanted to welcome you all, and also just a reminder for psychologists, please email me after the talk in order for you to be eligible for your CEs. Dolores and I are really thankful that you've all come today and looking forward to seeing you at our next talk in about 2 months. We'll send out announcements shortly for those. Paul?
Yeah, thank you, Shilpa, and welcome everyone. So nice to see people from across the whole Mount Sinai health system and people from the community as well. We really opened this up and are excited to see you all. This is the second in our series of new Just Talks, equity and social justice in mental health. For the broader community, and it's really important discussions that we're having and learning that we're doing together as sponsored by the DEI committee for our department across the Mount Sinai health system. So we are really delighted to have a speaker today who is a new faculty member at Mount Sinai as of this very month. Dr. Sidney Hankerson is an MD and MBA, associate professor and Vice Chair for Community Engagement in the Department of Psychiatry at the Icahn School of Medicine at Mount Sinai as of, I think, 2 weeks ago. Welcome. He is Director of the Mental Health Equity Research program in the Institute for Health Equity Research at Mount Sinai. And his research has really been focusing on reducing racial and ethnic disparities in mental health treatment. One of the strategies for doing that is partnering with community members, community churches, and to develop, implement, and test culturally relevant mental health interventions. So he's going to talk about some of that today. He's a nationally recognized expert at faith-based mental health services research. He was named in 2021 by the National Academy of Medicine as one of 10 physicians nationally to its prestigious Emerging Leaders in Health and Medicine program. New York City's prior mayor, de Blasio, appointed him as chair of Community Services Board of the New York City Department of Health and Mental Hygiene. And he's presented his study results at the White House, the United Nations, National Institute of Mental Health, SAMHSA, the mayor's office, and numerous academic conferences. He was an inaugural member of the APA's Council of Faith and Community Partnerships and served on the APA Council of Minority Mental Health and Health Disparities. And he completed his dual MD and MBA at Emory University, where he was the medical school class president for 2 years, and then completed residency also at Emory and was named chief resident at the Grady Memorial Hospital, and then completed an NIMH T32 postdoctoral research fellowship at Columbia and was on faculty at Columbia prior to transitioning to his current role here. So we welcome you warmly and to the department and to this forum to share your wisdom and research work with all of us. So thank you for joining.
Thank you so much, Paul, for that really warm introduction. And good morning, everyone. I'm really excited to be here. A little bit anxious, to be honest. You know, it's always interesting presenting to your colleagues and friends. And so really excited to tell you a little bit about me and the work that we're doing with community engagement. I will share my screen. So during our time together today, I'm really going to focus on how we can leverage community engagement to promote mental health equity. Since this is a CME talk, I do have no conflicts of interest to disclose. I first want to thank just the many people who have supported me already so much at Sinai, to Carol and Lynn, who lead the Institute for Health Equity Research, which is my primary academic home, to Renee Kahn, of course, chairman of Psychiatry, who's been just really outspoken and wanting to focus on community outreach and engagement in the department, to Ken Ashley, my longtime friend and colleague, Reg Miller, and to the entire Psychiatry DEI committee, as well as the Center on Spirituality and Resilience. I'm excited to work with them. I thank Amita for making the jump with me to Mount Sinai from Columbia, and Jide Williams, who has just been an amazing partner and mentor to me over the years. And certainly to the Community Coalition for Mental Health, which supports all of my studies. Breaking our talk down into really 4 sections. My research and clinical focus is depression. So kind of briefly go through some of the factors that contribute to disparities in depression care. And then talk about why I've decided to partner with faith-based organizations. Then go over some principles of community engagement. And then really open it up for discussion. I look forward to the days where we can meet in person, but really want to hear from you through the chat, and please feel free to reach out to me afterwards about how we can elevate community engagement in psychiatry. So African Americans with depression just have a dramatically different course compared to white Americans with depression. And there are differences in the prevalence and disability and treatment of depression based on race. This data is from a nationally representative survey called the NESARC, which shows racial differences in depression over 12 months and over lifetime. And we see this in nearly every epidemiological survey published, that African Americans have lower rates of lifetime depression, as well as slightly lower rates of 12-month depression compared to their white counterparts. However, African Americans with depression are more disabled or more impaired compared to white Americans with depression. Data is from another nationally representative survey looking at disability scores. And in every area of disability, you see that African Americans with depression have higher rates of disability in terms of work, relationships, social functioning, and an overall disability. And indeed, on clinical measures, depressed African Americans have more severe symptoms and are sicker for a longer period of time. And so it's no surprise that there are disparities in treatment for depression. One of the first studies that I did used that nationally representative survey, the NESARC, to see if there were differences in clinical outcomes or treatment for depression among Black and white adults. And we found that among Black adults with depression, they were nearly half as likely, these are odds ratios, to receive any type of treatment, whether that was psychotherapy and medication management. But Black adults with depression were nearly twice as likely to be hospitalized, really emphasizing the need to develop more upstream approaches and ways to engage African Americans into outpatient care. Highlight some gender disparities that contribute to these treatment disparities. Black men are much more likely to present to psychiatric care through law enforcement or through the criminal justice system. And so the criminal justice system, especially as it relates to Black men, is an important element and factor for us to consider. To Black men that impacts all of us is the history of psychiatric misdiagnosis in men of color. This is an image from a medical journal in the 1970s that was published in Jonathan Metzl's book called Protest Psychosis, which really shows how psychotic disorders and schizophrenia became racialized. This is an advertisement for Haldol, and you see the tagline, assaultive and belligerent. And then a man who looks, to me, for those who are old enough to know, this looks just like James Brown. And so you have, this assaultive and belligerent, and then Haldol. And I show this to really highlight the fact that Black and Latinx men with psychotic symptoms are more likely diagnosed with schizophrenia compared to white men with psychotic symptoms, or more likely diagnosed with bipolar disorder with psychotic symptoms, or more major depression with psychotic symptoms. So it's really incumbent upon us as clinicians to tap into our own biases to try to eliminate some of these misdiagnoses in care. And so racism is certainly, in my view, a fundamental driver of these mental health inequities. And so I love Kamara Jones's framework, where she looks at institutionalized or structural racism and how that impacts access to education, housing, healthcare, and the criminal justice system. And then individual racism, which are individual acts of prejudice or discrimination or microaggressions that we have become so familiar with in the last several years. And then perhaps the most insidious impact of racism is internalized racism, where the racialized and minoritized group experiences self-doubt, hopelessness, and racialized inferiority. And so I believe that institutionalized, structural, individual, and internalized racism are fundamental drivers of these disparities. And so one of the, I think, important things for us to consider as clinicians and as researchers is how does structural racism impact the intergenerational transmission of depression? So I was fortunate to be a part of a special volume of the American Journal of Psychiatry that's going to be published in June of this year, looking at the impact of structural racism across the real gamut of psychiatric disorders. And so my colleagues and I, including Rachel Yehuda here at Sinai, I created this framework that really explores how structural racism can interact with cumulative trauma, including historical trauma and ACEs, to really impact and contribute to the intergenerational transmission of depression. So I think exploring how these things interact individually and across generations is really an important next step in our exploration of disparities research. With all of that, so I went through that kind of quickly. So now we can get to what do we try to do about structural racism and really promote equity as it relates to mental health. So almost 20 years ago, there was really a landmark paper that showed that across the United States, regardless of a person's racial or ethnic background, and regardless of their religious affiliation, more people in this country initially, when they're experiencing a depressive episode, first seek care from a clergy person, from their pastor, or from their rabbi, or from their imam. More often, they initially seek care from psychiatrists. And this data was from the National Comorbidity Survey replication. You see that the first group contacted initially is mental health professionals, which was a combination of psychologists and social workers. And then clergy were second. So clergy and our faith leaders are really frontline mental health professionals. So in the African-American community, our churches and houses of worship are really central institutions. And African-Americans are the most religious group in the United States. So it suggests that houses of worship could really be vital as access points in identifying and supporting people with mental health challenges. 87% of African-Americans belong to a religious group. 79% say that religion is important, and 53% attend church at least once per week. And while admittedly, nationally, in the midst of COVID, there has been a national decline in church attendance and engagement, in large part because many of the churches were closed during the pandemic. That rate of decline has been least or slowest in the African-American community. So churches still remain vital institutions in the Black community. And so this suggested that churches may be viable settings in which to provide access to mental health and depression care. But I certainly want to acknowledge barriers to depression care in faith-based settings. There's certainly a history of negative perceptions of depression in churches and religious settings, often ascribing mental health conditions to either personal sin or a lack of faith. So that was something that we had to address and acknowledge and overcome. There's also this notion of religious trauma to people who identify as LGBTQ+. So it's important to acknowledge that, religious institutions have oftentimes been tremendously harmful to members of the LGBTQ+ community. And so that was a barrier that we needed to acknowledge and figure out how to address. And then the reality is, obviously, for folks who don't engage in church or are not religious, this is not going to necessarily impact them. So acknowledging the limits of church-based care was important. A lot of those limitations, one of the first things that I did was to try to see if it was feasible to provide church-based mental health services. And so we conducted focus groups with pastors, with 21 pastors, and you see their demographics here. Most were women, a highly educated group of pastors. Nearly 90% had a master's degree or higher. This was from a huge church in New York City with over 20,000 members, and it was the African Methodist and Episcopal denomination. A couple of key themes from these focus groups that really dictated and really drove my approach and my work over the last several years. So these focus groups were conducted 10 years ago. And even then, the issues of racism surfaced prominently in the focus groups. One of the pastors explicitly talked about the impact of slavery, white supremacy, and institutionalized racism as causing depression. And so this highly educated group of clergy did not see depression primarily as a psychological or medical condition, but social condition that resulted from the institutional and structural barriers that impact the Black community. Came up was around stigma. This quote from one of our pastors just said, we don't think that counseling is for us. And so this notion of Black folks not seeking mental health services was something that we needed to address head on, as well as acknowledging a history of a mental health system that has often been harmful towards members of the Black community. And then one of the other key quotes was the importance of partnership. So one of the pastors, I conducted all of focus groups, and one of the pastors said, Dr. Hankerson, we like you. You seem to be like a genuine guy and a nice guy, but you're not just going to drop in here like some other researchers have done a study and then published a paper and not returned anything back to us. You have to partner with us for there to be any chance of any type of church-based depression work succeeding. And so this notion of partnership really led us to think about how we can formalize relationships with pastors and how we can then identify people who may be at risk for depression and who may need services. Partnership with pastors from that church and then from two other churches, a church in Harlem and then a church in Brooklyn. We conducted the first ever depression screening study conducted in churches with a validated instrument, and we used the PHQ-9. So I'll walk you through some of what our sample and what our population looked like. So across these three churches, we screened 122 adults with the PHQ-9. We were able to recruit a high percentage of men, nearly half of the sample were men, and the average age was 54. Identified a wide range of incomes. And so I show this because sometimes when people talk about health disparities work and work with churches, they think that it's just for people who have limited resources, but churches really cut across the entire spectrum of the Black community, and that's reflected in this slide of diversities of incomes. It was also a relatively highly educated group in terms of 48% of the sample had graduated from high school and 47% had some college or technical school. And nearly 90% of the sample had some type of health insurance, either public or private. These three churches, we found overall the rate of a positive depression screen, which we defined, consistent with the literature as a PHQ-9 greater than 10, Overall, the rate of depression was 20%. So that rate is in a general population sample. If in the general population, the rate of depression with the PHQ-9 pre-COVID was about 8%. So we found the rate of depression of 20%. Another significant finding was that men had a higher rate of depression than women. And this was really surprising because it's well established that women have 2 times the rate of depression than men. So we really needed to think about how to potentially target depression interventions, for men of color. So that really formed the foundation of our work for intervening and intervening really utilizing principles of community engagement. So community engagement, kind of broadly defined, is the process of working collaboratively with and through people affiliated by geography, by special interests, or similar situations to address issues affecting their well-being. And so this is the kind of broad definition of community engagement. Engaged research, really is centered on 2 key principles. First, it requires equitable partnerships between community stakeholders and academics. And second, it really links scientific inquiry with social activism. And I love this picture because as we think about the activism that arose over the last several years, it really was about social change. And so community engaged research really is about partnerships and linking inquiry to activism. And I do want to shout out, Dr. Horowitz, because she really was on the forefront of community engaged research before it became as popular as it is. So in the literature, there's a lot of different types of community engaged research methods, whether it's action research, participatory action research, CBPR, or community partnered participatory research, but they all essentially are rooted in those same principles: equitable partnerships between community members and academics, and really linking scientific inquiry and social activism. So I decided to utilize community partnered participatory research for a few reasons. One is that it's an evidence-based, really manualized model of community engagement that was developed for mental health services research. This method was developed by Dr. Ken Wells, a psychiatrist at UCLA, and the late Dr. Loretta Jones, who was CEO of an organization called Healthy African American Families in South Los Angeles. And this method, this community partnered participatory research, really emphasizes the equal partnership between community members and academicians. The 3 stages of engagement in a community partnered initiative. First is the vision. That's where the formation of the community advisory board or steering council, or in our case, we created a community coalition. That's where those group of stakeholders and academic partners really coalesce and form a kind of working group to identify an issue that is a priority for the community and cast a vision of what type of change wants to happen. The second stage of engagement is the valley. That's really the implementation, or the implementation of evidence-based practices. The work is in the valley. So doing the work of implementation is the valley. And then the last stage of engagement is the victory, where we celebrate our results, we share lessons learned, and then we recast our vision. So this is a really iterative process of vision, valley, and then victory throughout the process of a community partnered framework. So community partnered, participatory research is really rooted in two-way power sharing, and that is operationalized through the formation of a community coalition. And that coalition or that advisory board is co-led by a community member and an academic partner. It really emphasizes community empowerment, equality in terms of racial and ethnic composition, in terms of sexual and gender orientation, and certainly respect for diversity. And this approach has been shown in several randomized controls trials to increase participation of folks of color in research studies. It builds trust with the community and community-based organizations that participate. It increases capacity of the local community to address problems and increases capacity through policy change. And it also has been shown to reduce disparities for mental health problems. So I did a community coalition using principles of community partnered research. And we have a four-pronged mission, which you see here. First is really to reduce mental health stigma and promote social justice, to build community and academic partnerships, to increase awareness about depression. And really, our last mission, our last part of our mission was very specific. We really wanted to promote help seeking for mental health problems for people in Harlem, with a specific focus on people of African descent in faith-based settings. So integrating and working with faith-based organizations and folks of the African diaspora was really what our coalition decided to focus upon. I just have a quick video to show the members, or some of the members of our coalition. Now that video was a few years ago because I still had hair. But I will say that I hope that you were able to appreciate the diversity of our coalition in terms of its composition. And so we are really having with my coming to Sinai, they're really excited about expanding our work into East Harlem, and really welcome anyone who would like to participate or check out our meetings, because we really want to kind of reboot Community Coalition 2.0. And really, I need to hear from you all and your voices. So please feel to reach out if you're interested in supporting or coming to one of our meetings. And so I want to briefly walk you through how the coalition works and kind of how it's operationalized and how that may impact some of the work that you all are doing. And so there's several activities or action steps that we do. All of our meetings begin with an icebreaker. And the goal of that is really to deepen relationships, and it gives everybody a chance to share, because we know that in groups, there's some folks who tend to dominate the group, and there's some folks who don't speak up in groups, but the icebreakers allow everyone to share, so at least everyone's voices can be heard. As I mentioned previously, we've elected a community and academic co-chairs that really lead the coalition. The community co-chair is really responsible for setting the agenda for the meetings. And this is really intended to promote two-way power sharing, within the group. And then we signed a partnership agreement or a memorandum of understanding for every person who really commits to being a member of the coalition. It's an open group. So before people can vote as members of the coalition, we require that they attend at least 3 meetings, but we know that people are busy, so it's an open group. People can come and go, but the partnership agreement really formalizes, partners' commitment to the coalition. And then we, identified the mission and values, which was really designed to create clarity around the work. So the coalition has had just a huge impact on me personally, and I hope, the Harlem community with whom we've worked. So one of the outcomes of the coalition was to really have a mental health symposium that was designed to have people with mental health problems share their stories of getting treatment and recovery. And this was considered kind of an anti-stigma intervention. And over 400 New York City residents attended the very first symposium that we had at St. Charles Borromeo Parish in Harlem. And then the coalition really expanded the focus of my K Award. My K Award was initially focused on training pastors in an evidence-based intervention called interpersonal counseling. So Myrna Wiseman was my primary mentor. And our goal initially with my K Award was to train pastors how to use a brief version of IPT. But the coalition and then the pastors, once the grant was funded, said, we don't want to do that. So instead, we ended up training over and partnering with the Department of Health to train over 300 people at our partner churches in mental health first aid, because they thought that that would be able to reach more. And it definitely did. And then we also supported the work of First Corinthian Baptist Church. And First Corinthian has really become one of our main community partners. And the church created a freestanding mental health clinic called the Hope Center. And so I want to just expand upon the Hope Center a little bit. The Hope Center stands for Healing on Purpose and Evolving. And there's the website at the lower right of the page. But they are located 1/2 block away from First Corinthian Baptist Church, right on 116th Street in Harlem. And they provide evidence-based psychotherapy to community members in Harlem. And so they provide up to 10 free sessions of evidence-based, short-term evidence-based treatments, including CBT and IBT. And also, if people need longer-term treatment, they do make referrals to longer-term care. They provide individual therapy, family therapy, couples counseling, and do so in groups. And the most common presenting problems are depression and anxiety, and then trauma and grief and loss. And you can see there's a wide range of age range of people served at the Hope Center. 90% identify as Black. Most of the clients are women, and 30% identify as LGBTQ+. And so they have really done a huge job in addressing the needs of the LGBTQ community in our faith-based organizations. So we talked about the Hope Center a little bit. Lastly, in terms of the coalition's impact, they've helped to identify themes for a recruitment video for my current R1, and this is being disseminated through the network of church partners in New York City. Our coalition really said, after we created our first recruitment video, they said, it's okay, but you don't focus enough on the specific depression risk factors that Black women face, given the prevalence and the fact that many churches are mostly composed of women. You need to focus on women. So I do want to give Dr. Bernadine Waller, who I see on the meeting today, who was really instrumental in creating the script for this, but the coalition really emphasized and pushed us to help focus on the needs of Black women. And so I do want to play just a video that we are using as for recruitment for our R01 focused on Black women, and using community health workers to provide brief counseling and connect people to formal mental health treatment. Oh, I'm sorry. I did that.
If
The app that the volume is not coming through. So
if you want to unshare your screen, and then when you share screen again and click those buttons on the bottom that says optimize screen sharing, I think the video may come through better. Those two buttons on the bottom left.
I think that I would know that by now.
I always forget to.
Okay, thanks.
Looks like a
So
great
let's,
video. Yeah.
I guess. Take two. Can everyone see this?
Yeah.
Yes.
Okay.
I'm so glad I got to see y'all today. Man, ever since I lost my job, I've been really down with the bills piling up, and you know, I've been taking care of mom, and other than that, I barely get to see anybody.
Well, I'm just glad you decided to get out of bed today and join us. God does answer prayers.
You know, that sounds a lot like what I went through. Have you tried speaking with someone?
Well, you know, I'm just doing the job search and making sure Ma's okay. I just been really, really tired.
When I was down, Pastor told me about a study called Triumph. They have community health workers who work with those who are down, stressed out, overwhelmed, having trouble eating or sleeping. And with everything going on, it was a godsend. Between the Lord, Triumph, and me, baby, we got you covered. Hallelujah!
If you are a part of the Black church community in New York City, I want to personally encourage you to become involved in the Triumph study. If you've been experiencing any stress or anxiety or depression as a result of what's happening in our lives in this present day, please seek out the Triumph study. Call the number and get involved.
So, hope everybody saw that. So that's the primary recruiting tool that we're using in our R1, focused on women in the church. So lastly, I would just want to talk about and then open up a discussion about hearing for you and how we can really elevate principles of community engagement in psychiatry. I've been privy to some of the amazing work of the Center on Spirituality and Resilience and the work that Shilpa is really leading with youth and substance use. But I'm excited to learn more and meet everything that you all and we all here at Sinai are doing. And so basically for my current funded studies. I have 3 federal grants. R01 are from NIMH, that's the Triumph study. R01, that's part of a larger P50 grant from NIMHD. And we just got a NOGA for R34 from NIDA, which is focused on a church-based naloxone intervention. And so the coalition really has been integral in all of those studies. It's also really shaped the direction of some next research ideas, including, in partnership with Dr. Williams, using hip hop to prevent youth suicide. That the coalition has really identified addressing Black youth suicide as crucial in the Harlem community. And we've also submitted a grant through the American Foundation for Suicide Prevention on a church-based intervention to prevent suicide among Black youth. And so, as I close, I'll just really open it up, for discussions and feedback, and ask, how do we really elevate the voices of community stakeholders, in the Department of Psychiatry, and how do we build an army of clinicians, scientists, and advocates who really live and breathe, principles of community engagement and equity. And lastly, how can I support your work? I really see my role both in IHER and in psychiatry as supporting and elevating the work that we are doing here at Sinai, and leveraging some of the partnerships that I have to expand and create synergy, as well as think about disorders and populations that traditionally have not engaged communities of color. And how do we do that equitably? And how do we do that with rigor? And so with that, I'll end my talk and open it up for questions.
Thank you so much. Wow, that's really amazing work, and I think we have a lot to learn. I don't think we are very good at elevating the voices of our community and listening to the voices of our community. We are, often more insular, and I think we have a lot to learn in this realm. So thank you. I loved the quote in the video. Between the Lord, Triumph, and me, we got you covered. It's really a beautiful partnership between the church community, which sounds like, I think it provides a tremendous amount of support, as well as the additional support for mental health that they can collaborate together to help individuals. So I open up to questions. People can either put a question in the chat or unmute yourself. I will try to keep some order. If we have too many people also speaking at once, I will call on you. You can also raise your hand by doing reactions and selecting raise hand, then I can see you. So any questions, we have community members here. Please, we want to welcome you and welcome your voices if you have questions, comments. Trainees as well, we welcome your comments, questions. Okay, Mirla Parrish, please. Thank you for.
Thank you for that great presentation. I'm sorry, wait, I'm just gonna, I think that's better. I have two questions. One, in creating the board or the advisory, how was it to make it so diverse? Like, what were some of the challenges, or, always looking at how do you create balance and really have diversity and equity of power? So I wanted to ask that question. And I wanted to comment on the video. It was really good. As a Black woman, so identify, I appreciated the Mary Mary song in the background, the instrumental, and thought it hit a lot of key points, and like, what do you call it? Almost like a dog whistle for Black women in the church to recognize the language. And I also liked at the end, there was an invitation to get involved. And it didn't say what particular capacity, but to get involved. I thought that was great.
so much. In terms of addressing, the diversity and the equity of the group and how do we ensure power sharing, that's really evolved. This coalition started with myself, Reverend Charles Butler, who works for an organization called Harlem Congregations for Community Improvement. It's a coalition of over 90 churches, in Harlem, so they have a tremendous amount of reach. Also started with Martha Sullivan. She is a doctor of social work, and she's actually the CEO of Creedmoor Hospital in Queens. She's a member of a church in Harlem and a Harlem native. And we also started with Professor Laura Thompson from Teachers College, who is a white woman who utilizes principles of community action, community-based participatory research in youth in the South Bronx. And so I think that was kind of the starting group, and that group just said, to expand the coalition, why don't we have this symposium? And so we had the symposium. It attracted over 400 people, recruited people, and told people about it from all of the local graduate schools. And so we really got a rich array of, from generations, race and ethnicities, and genders. Although I will say now, most of the coalition are women. I would say about 90% of the coalition are women. So we've struggled with keeping men engaged. And also I would say about 90% of the coalition now is Black. So in that image, that was pre-COVID, that was several years ago. I do need to ask folks, especially some of the white members of the coalition, why they haven't, continued. And so that's kind of the composition of the coalition now. We have actually about 15 to 18 regular members. Most are women, and most are identified as Black. It's been a journey in terms of, continuing the diversity, especially across ages and generations.
Thank you. I'm going to take one chat question and then bring it to the next person with their hand up. So is there a referral process for the Hope Center? I wonder what the best way to get patients connected to the program.
Sure. Yeah. I mean, I can certainly put the information for the Hope Center. There's a direct number to call, and through the website, there's a very straightforward kind of intake process.
Great. Yeah, the website. Great. If you can just introduce yourself before you ask the question, and then go ahead. So Dr. Singh, please.
Hi, thanks for a great talk, Pramit Singh. I oversee psychiatry for the health system. I'm an addiction psychiatrist, so I'll disclose that in the entrance of any bias you may hear in my question, which you undoubtedly will. I did overhear you talk about, you mentioned naloxone briefly. Spirituality and the church has actually been a larger part of addictions treatment in all communities. I mean, there are many people who will turn to the church rather than to, an institutional treatment program to and sometimes quite successfully to get sobriety or abstinence. Perhaps you could talk a little bit about what we as an addictions treatment community can do to gain more acceptance within any particular groups, and if you have any experiences with that particular issue, in addition to your work with depression, of course, that you talked about.
Yeah, I mean, thank you for your question. And so our R34 has not yet started. It's, we'll be starting soon. But what I think was innovative about our proposal was that we really acknowledged that especially in the Black church community, there's a tremendous amount of stigma around drug use. And so we really made that addressing stigma through the use of a contact video-based intervention a central part of our naloxone program. And that really received high scores from the reviewers. And so our thoughts for that are to have both a pastor and a person with lived experience with opioid use disorder share their stories through a video contact intervention that can be disseminated through our churches and will serve as a precursor to us implementing this naloxone intervention. So I would love to learn more from you, as we are unrolling this about how we can better incorporate spirituality in addressing, opioid overdose. And I see Yasmin's hand raised, so I definitely want to defer to her and her expertise as well, and look forward to working with you both within this.
Dr. Hurd, please. Yes. Yeah.
Sorry, so Yasmin Hurd, Director of the Addiction Institute at Sinai here. Sorry, I'm just lowering my hand. And so for me, raises, some of the questions that I had. But one of the things that I think that's really critical, and we would love to get community engagement, is about education. Because to me, that's one of the critical things. So definitely, having people partner for treatment, but education, and especially children, the earlier start, the better, and teens, and to bring the parents along with them. And so being able to have the community help us with that would be really, I think, powerful. So happy, we'll definitely work together.
Wonderful. Thank you.
Thanks. Just going to go back to the chat. So Leila Talhouk said, thank you for sharing your work with us, Dr. Hankerson. I'm wondering if you've also collaborated or plan to collaborate with Muslim community leaders or those of other faiths.
We are planning to collaborate explicitly with the Mosque of Islamic Brotherhood on this R34. As soon as it's funded, I have worked with their imam for several years. And when I first went to meet him, he had a DSM in his office, and he talked openly about some of the mental health challenges and depression, especially among men in the mosque. So I'm definitely excited about expanding, work with mosques.
Great. We have a couple questions asking Jasmine Edwards, for example. I'm a music therapist in pediatric department and have seen how using rap and hip hop with Black adolescents who prefer or connect to the genre can be crucial for identity development. Can you talk a little bit more about this new study?
It's very much in development, and I think that it's kind of built on the notion of, just as you said, that music has soothing, and there was a study that came out, I think in England, that showed that hip hop can reduce suicidal thoughts among teenagers. And so our thought was to try to leverage that, the New York City schools and other community partner networks that Sinai has, as well as in West Harlem, to try to implement kind of a school-based hip hop will address suicide in youth of color.
Great. Question from Norma. If you, Desmond Heath, if you'd like to ask, give me one sec. You'd like to ask a question? You unmuted. Okay. Congratulations on your work. Are there near future plans for making mental health more accessible to communities of color served by the Mount Sinai health system, where the need and demand has multiplied exponentially during COVID? I don't know if you're able to answer that question, new faculty member. It is definitely, I think access to care is such a huge issue across the city, across the nation, and it is really a national crisis. And I think we are trying to contribute to addressing that crisis, but I think there needs to be also advocacy on governmental and our higher levels. I don't know if you have other comments or if anyone else has a comment on that, but certainly that is a priority for our departments to do our best providing access. Does someone else have a question on the screen? Desmond Heath, please introduce yourself and go ahead.
Sidney, have you tried anything in the way of the open dialogue, non-hierarchical family group meetings in your work? Because, well, I leave that as a question. I think your video starts off wonderfully with the family, but then sends a kid out somewhere else. They should ask the folks to come into that home and do an open dialogue family group meeting, because the studies show that is so much better long-term for schizophrenia. That's my study, children, how they convert from childhood conditions to psychosis and schizophrenia, privately funded, and so nobody listens to it. Have you studied, found out about the open dialogue method started in Eastern Lapland and much more effective in treatment of psychosis than what psychiatrists offer today? No wonder we can't get it across, because it ain't no good, our treatment methods. Let me let you respond to that. Open dialogue. Do you know about it? Have you used it?
Heard about the open dialogue methodology explicitly. However, I will say that we certainly are focusing on family-based interventions. And the whole premise of the R1 is to use kind of trusted family members kind of within the church to be the primary interventionists. So I certainly believe in the notion of open dialogue, and I look forward to learning more about that particular methodology.
I would like to visit you personally or on Zoom. There's enormous resistance to this in the psychiatric community, using parents and grandparents and teachers as the primary people in the open dialogue team. The physician is non-hierarchical. We can set it up.
That's a wonderful, wonderful idea. I'm going to ask, we have time for one last question. I'm going to open to Reverend Dr. Zarina Costello. Please, if you could unmute yourself, and welcome.
Welcome, welcome, welcome to Mount Sinai, Dr.
Thank you, thank you, thank you.
So nice to be in the Zoom meeting with you.
Indeed, you as well.
And your programs are amazing, and we are just so excited to partner with you on behalf of the Center for Spirituality and Health and the Center for Stress Resilience and Personal Growth. And so around 2016 or so, we surveyed many of our partner faith-based organizations as to what were the top priorities and concerns of health in the community. And mental health was the first identified area that they needed help with. So it's so consistent with your work and findings. At this point, I'm just wondering, and you know, I know that this is the beginning of something great, how we can integrate what we've been doing in terms of education, training community health advisors, being present and supportive of the faith-based communities, both Christian, Muslim, and other. In terms of the work you're already doing, do you envision integrating these efforts, or what are your thoughts on that?
Absolutely. So first of all, let me just publicly say it's so wonderful to see you and Deb and Jonathan have been so supportive, you know, through me over the last several months. So I am thrilled at the opportunity of to collaborate and to really create more synergy and, you know, expand our collective efforts. So I am really excited to work with you.
Thank you.
Sadly, we are out of time. We have so many more questions about intersectional identities and about the intergenerational trauma and depression. And I hope that we can continue this dialogue in other forums. And I want to thank you so much for joining us, and all of you for joining this special talk today.
My pleasure. Before I go, I just want to acknowledge Reverend Dr. James Johnson, who I see. And if there's anyone else from the coalition who's on today's talk who I didn't see, thank you for taking the time to come out today. So thank you.
Thank you all.
All right. Thank you all.
Take care.
All right.
Thank you.
Bye, Sidney.